Welcome, everyone. Welcome here. We'd love you to put your where you're coming from in the chat if you'd like. If you want to go in the chat and say where you're coming from tonight, that would be great. So welcome here. We'll give people a minute or so to enter in. We know we have quite a few people that have signed up to join us tonight. Thank you, Denise from Vancouver. Nice to see you. And Marie, hi Marie from Delta. And Marie, thanks for sending in your thank you video to Pathways. We played that at Circle of Strength. So thank you for doing that, Marie. Yeah. Welcome Sydney from Victoria and Linda from West Vancouver. Hi, Linda. And Gabriella from North Vancouver. Annika, hi Annika from West Vancouver. And Lori, hi Lori from North Van. And Jean from Vancouver. Nice to see you all. Hello, Brenda from Vancouver. And Linda from Chilliwack. Hello, Harriet from Vancouver and Georgia from Langley. Welcome, everyone. So nice to see you all. Oh, welcome, Karen from Whistler. Thanks for joining us, Karen. It's our great volunteer in Whistler. And welcome, Monica from Comox Valley. That's a beautiful area of the world. And hello, Andrew from North Van. Great. Great to have you all here. So people are still coming in. We welcome everyone. And if you want to put where you're coming from in the chat, you're welcome to do that. Hello, Joseph from Vancouver. So thank you so much for joining us today. That's great. So we are Pathways Serious Mental Illness Society, and we support and educate families who have a loved one with a serious mental illness. Welcome, Shirley from Musqueam, Squamish, and Tsleil-Waututh Treaty areas. Hello, Susan from Vancouver. Great to see you. Thank you all for coming. And yet, if you want to put where you are in the chat. And so we'll get going here. I'm Liz Sharna, the Executive Director of Pathways Serious Mental Illness Society. And for 30 plus years, we've been supporting and educating family members who have a loved one with a serious mental illness. And one of the ways that we do that is through our NAMI Family to Family program that we offer throughout the year, as well as we have support groups and one-on-one support. And then we also offer these lectures sometimes. And we're so pleased that Dr. Randall White is here with us tonight. So Dr. Randall White is Division Head for Adult Psychiatry and Mental Health Services at UBC. And he's also the Medical Director for Community Mental Health Services in Vancouver. As a member of the UBC clinical faculty, Dr. White delivers academic lectures on a wide range of topics, such as psychosis, clinical decision-making, psychotic disorders in DSM-5, and aspects of treatment-resistant psychosis, just to name a few. Dr. White is the recipient of numerous awards and honors, including the American Psychiatric Association John B. Hackett Leadership Award and the Special Service Award from the Vancouver General and UBC Hospital medical staff. We appreciate Dr. White's generosity in sharing his time and expertise with us again. Dr. White will not be able to comment on personal medical circumstances, but he will be commenting generally and answering people's questions. We have received a number of questions already ahead of time, and so we'll be answering those at the end. So we're going to have everybody muted, and we'll have Dr. White do his presentation, and then we'll have him answering some questions at the end. So welcome, Dr. White. Thank you so much for being here.
All right. Thank you, Liz, for having me. And I'm taking stock of all the questions that you've submitted because I think those reflect a lot of the concerns that, all the families that I'm familiar with go through. And one of the big themes that I see is how do families interact with care teams, and how do families have their input be taken seriously, um, and how do they ensure that what they know about their family members, their loved ones, um, how is that information conveyed to the doctors, to the nurses, to the case managers, et cetera. So, um, this is a complex issue because healthcare is complex and is governed by a variety of laws, as well as, of course, professional, um, organizations that nurses and doctors and others have to abide within the rules of, like the College of Physicians of BC, or the College of Nurses, and then there's the health authority that is funded and organized to deliver health care. So, all of these organizations have, as I was saying, their sort of reasons to exist, reasons to justify their existence sometimes, and the requirements of their members, their staff, and their employees. So, um, but there's no formal representation per se for family members or even patients, other than their ability to sometimes be invited into, for instance, health authorities to give some input, to participate in committees, um, and also there is now, with some new health laws that have been passed and new sort of government initiatives and organizations, this new law called the Health Professions um, Act. So there's now opportunities for members of the public to be represented, um, on the governing boards of some of these organizations. That's coming, for instance, for the physicians, the College of Physicians, um, and and even health authorities, for that matter, have appointed boards. And, there are ways for people to um, signal their interest in, having some of these appointments. Um, so that's something that, you all perhaps can be aware of and think about, even as an organization. Like, is there a way for you as an organization, people in pathways in the BC Schizophrenia Society, to decide among yourselves, is there somebody you would want to be represented in some of these organizations? There's something else that's important called the Mental Health Review Board, MHRB, we call it, our Mental Health Review Board, which um, by law um, is it's a non-judicial tribunal that is established because of the law of British Columbia when it comes to mental health, the Mental Health Act of BC. And that organization, MHRB, has to uh, provide review panels for the patients who are under the Mental Health Act to request them. And so the review panels all have a community member on them. So each review panel, when a patient requests one, will, hear the input of the hospital as to why a patient should perhaps remain in hospital and continues to meet criteria under the Mental Health Act. And then the patient has the opportunity to say why they feel they don't, and they can, of course, be represented uh, or have an advocate if they wish. But in any event, uh, the review panel consists of a lawyer, a doctor, and a community member. So, um, that's another way that the public can be represented to, uh, be appointed as community members on review panels. Um, so these are just some opportunities I thought I would mention for families and organizations to consider. And there are others too. I can't go through all of them. There's actually a website, a BC government website, which when opportunities arise on all these bodies, you know, indicates we're accepting applications. And I'm forgetting the exact acronym or name of this website, but in any event, I'm sure you can easily find it. So back to how families, when it comes to just your individual member who is affected by mental illness, how you can influence their care team. And I think that in general, even though it seems like there is sometimes this wall of silence, in general, the colleagues I know value input from family members, but some of them, I think, perhaps are over-interpreting what they see as their ethical obligation to maintain a strict level of non-disclosure, confidentiality, when they're treating a patient who says, I want no communication about my situation with my family. And the rule of thumb that I think a lot of us, I follow, and that I try to get physicians who work in our programs to understand is that we can always accept information from families, from people in the circle of care, especially if a patient or client is living at home with their parents, with their siblings, whatever. And those family members have responsibility for the person. The person's going to be living there. Family members are going to be involved in getting them to appointments, making sure they get their meds and all these things. So that is, undeniably part of the circle of care. So there has to be some communication. And, if the patient, though, says, no, I don't want communication, then, as I said, we can accept information. And, because without it, we're kind of flying blind a little bit. If we don't understand the implications of decisions that we make when the person goes back to where they're living, and what a family can realistically provide. So we absolutely must understand that to deliver safe care. Um, Usually, you know, if we work with a patient enough, we can gain enough trust so that, they will allow us to, have more two-way communication. And, ideally, the way I like to do it is to, um, certainly with patients that I'm treating at UBC Hospital, is to have the family come in. Patients may say, no, I don't want my family involved. And, sometimes that's fairly absolute and they won't even want them to come visit them. But in quite a few cases, they'll say that, but they want to have a pass, right? They want to go places. So, um, the family may show up to take them somewhere. And then I immediately would seize on that opportunity and say, well, before you go on the pass, we have to talk with your family to find out what you're going to do, and et cetera. And then we can have a little meeting and sort of break the ice. Um, so, that's something you could perhaps suggest in certain situations, like, we want to, if the person's in hospital, we'd like to take, um, John over to his favorite restaurant on a pass, whatever, and could we sit down with the doctor or the nurse and just talk for a few minutes and, see if we can get some communication going. Um, so that's one idea. And, you can be a little shameless in using leverage to offer the person, the patient, something that they want, which is getting out of the hospital for a little while. Um, so, so that's just one idea. The the other thing is, as I was suggesting, we can't really deliver safe care if we don't know how the person's going to be supported or living in the community. Now, if they're going to, supported housing, um, then there may be staff, maybe nurses who can, give meds, or staff who will, help with ADLs and that kind of thing. Um, so the family may be less involved and may have a little bit less um, kind of influence or responsibility. But, supported housing is not available for many patients who require it. And, so family caregiving is very widespread and, a big source of stress and burnout. And I think that we, as health professionals, we need to understand the risks that family members face in these situations where they are, by default, giving a lot of care and support. Um, and since we don't have enough supportive housing, if the family is unable to, sustain that, um, then, our patient, whatever I hope we're thinking about the family in that way. We sometimes may not for different reasons, or, it's not malignant. It's just, having too many things, too many patients sometimes, too many complicated situations. But I mean, at least we should be able to remind ourselves that if that family safety net is gone, then our patient ends up on the street or something, possibly. And so that's another rationale, I think, to ensure that families, are involved and supported as much as feasible. Um, and I've had plenty of patients who unfortunately did reach that point where, um, they could no longer stay in the family home. They didn't have any place else to go. So, those are the terrible situations where people are on the street, or end up in the SRO on Hastings, etc. So, and there are lots of other, reasons that people take that unfortunate path over the course of their illness. But so, that was one theme I saw in the questions that I wanted to address up front. I think one more before we just focus more on the specific questions is a number of questions about medication. So I thought I would just give a little primer, a reminder about the different kinds of medications, and they get prescribed for people with severe mental illness, and maybe just a few things about safety and side effects, that kind of thing. Um, so, the broad classes of medications are the antipsychotic medications, the antidepressants, the kind of sedative um, medications, main ones being benzodiazepines, and then the mood stabilizing medications. So, antipsychotics are, of course, to treat psychosis. They're used not just in schizophrenia, though, they're used also in um, schizoaffective disorder and bipolar disorder. Schizoaffective disorder is kind of a hybrid, I guess, between schizophrenia and bipolar or severe depression. Has specific criteria in DSM-5, and it's challenging to diagnose, and some patients kind of move back and forth across that spectrum. In any event, antipsychotics are for the hallucinations and delusions that occur in psychosis, and they all affect, for the most part, not all, because there's an exception. I'll talk about a new medication. But anyway, the ones we have in Canada really all affect dopamine, a particular neurotransmitter. And dopamine has a number of functions in the brain. And so when you affect dopamine, you affect not just thinking and perceptions, which are disrupted in schizophrenia, but also movement. So people on high potency antipsychotics can develop movement disorders of various kinds. And the kind of worst one that can be irreversible is called tardive dyskinesia. Fortunately, it's not as common as it was 30 years ago when some people developed severe tardive dyskinesia, which causes abnormal movements of the face, the tongue, and can be disfiguring. We don't see that as much, but it can still happen. So, the common antipsychotics, risperidone, paliperidone, haloperidol, and olanzapine, quetiapine. And then some of them come in a long-acting injection form, in particular paliperidone, and another one called Zuclopentixol, and also aripiprazole. I'm not using the trade names. We tend not to do that, or try to avoid it in formal lectures, but I guess in this audience it doesn't matter so much. So aripiprazole is Abilify, for instance, and paliperidone is Invega, so you might hear those words instead. So the long-acting injectable means that you can give a shot either in the shoulder, the deltoid muscle, or the hip, the gluteus muscle. And there are different reasons for different places to give the injections. In any event, with some of the medications that need only be done every 3 months now, but in most cases it's every 4 weeks. So those treatments can be very helpful and effective for people who fail to take their meds, who for different reasons don't feel they need it, or just are too disorganized to take them. So um, that kind of treatment, the injectable antipsychotic, is probably underutilized. So if you have a loved one who needs an antipsychotic but keeps failing on it, not taking it, then this should certainly be brought up as a possibility. Um, then there's a specific special antipsychotic that we use a lot at UBC Hospital in the psychosis program called clozapine. If a patient has had good efforts with two or more antipsychotics, but two would be kind of the standard number. And they took them, or they got enough of the medication over a period of at least, let's say, 8 weeks, and they still didn't get better, then they would be eligible to have clozapine. But clozapine is um, a little bit riskier than the other antipsychotics. It can cause some blood problems, rarely heart inflammation. It also causes sedation, weight gain, drooling, and some other things that are kind of unpleasant. However, about 30% of patients really won't get better unless we give them this medication. So, and we can usually manage side effects, and studies have shown that, first of all, people with schizophrenia who don't take any antipsychotic have a higher risk of death and a shorter lifespan than those who do take medication. And those who are on clozapine, actually, despite having weight gain and these other risks, um, have even a better or lower mortality or death rate. Um, and it's probably in part because it seems to be very effective in preventing suicide in people with severe psychosis. Um, it does require month or weekly blood tests, at least for the first while. And so that sometimes seems to be the stumbling block, but it doesn't mean that it can't be successfully used in quite a few patients, I think, who aren't getting it now, unfortunately. So, all right, so that's antipsychotics. Then antidepressants we use when patients with schizophrenia or schizoaffective or sometimes bipolar get depressed, but um, they can also trigger a switch into the manic phase of bipolar disorder. So um, treating depression in people with bipolar or schizoaffective can be tricky. And so in general, in those situations, in those diagnoses, we try to stabilize people's mood with something like lithium or maybe valproic acid or Epival, and ideally that prevents depression and manic episodes, but preventing and treating depression seems to be more challenging in these populations. Sometimes we end up prescribing electroconvulsive therapy or ECT for that. I'll come back to that a little bit in a minute. The So I've mentioned the mood stabilizers. I'll mention, that lithium is the most well-studied and effective mood stabilizer, especially for people with sort of classic, what we call bipolar 1 disorder. But it also is a little bit tricky to take over the long run. It can be toxic in overdose. Or even if someone, for instance, just gets dehydrated, let's say they get a fever, they get dehydrated or diarrhea, they can become toxic on it. So it does have to be monitored with blood tests. Um, the blood level. And then rarely it can cause deterioration in kidney function. So that has to be monitored too. Also, thyroid function has to be monitored. So while it can be very effective, and it also, like clozapine, has evidence of being very effective in preventing suicide in these populations, um, it does require careful monitoring. And then then I'll talk for a second about the sedatives, benzodiazepines. So those are used a lot in acute cases, like in the hospital and emergency, just to, if someone is very agitated, very manic, very paranoid, they're, helpful to kind of take the edge off and reduce that level of excitement or aggression even. And in general, though, they don't have a role in sort of long-term treatment of these disorders. Unfortunately, some people seem to end up on benzodiazepines, but you may not know what I mean by benzodiazepines. So I'm talking about things like Ativan or lorazepam, diazepam, i.e. Valium, um, alprazolam. There are a bunch of these things. They all end in pam. But lorazepam is one of the most commonly used ones. It can be given orally, it can be given by injection, so it's used quite a bit in emergency departments. Um, so, uh, in general, it's best practice to only use them short term and then take them off. And unfortunately, some people seem to be on them for a long time, months or beyond. Um, it can be very difficult to get someone off benzodiazepines after a period of weeks to months. And, you know, I've had a patient who was on a high dose of one for, 20 years, and even reducing the dose slightly seemed to exacerbate psychosis, not just anxiety, but psychosis. It was very, very difficult. So the other thing is studies have shown, large population studies have shown that people with schizophrenia who are on these medications for prolonged periods have a higher risk of death. It's probably related in part to accidents, in part to overdose risk. Um, they also suppress a respiration, especially in combination with like alcohol. Um, so anyway, yes, I try to get all my patients off them whenever possible, but it's not always easy. Um, and then I think I've covered all those main categories. So I'll come back to ECT for a second. Electroconvulsive therapy is a treatment that was developed originally for schizophrenia, actually, not for depression, even though in the, current um, landscape of psychiatric treatments, it's sort of seen as a treatment for severe or psychotic depression. But uh, you know, back in the early 20th century, there was this observation that people with epilepsy and psychosis had this sort of alternation between psychosis and having seizures. And when they were having seizures, their psychosis seemed to kind of, moderate. And so, neurologists and psychiatrists started wondering, well, do seizures treat psychosis? So there were efforts to induce seizures in people with schizophrenia, and it did seem to help, but the way they did that was quite brutal by giving them injections of insulin, which cause low blood sugar, which triggers seizures. But they're uncontrolled seizures, and low blood sugar or hypoglycemia can cause brain damage. So that was seen as a not very good practice in the long run. But it did seem to show some short-term improvement. So the next thing was using penicillin or metronidazole or anyway, some other thing that can induce seizures. And again, these were uncontrolled seizures. Finally, somebody had the idea, well, maybe we can use an electric current to induce seizures. So that's how ECT evolved. And again, this was in schizophrenia. And Um, so we do use ECT now, and the patients are under general anesthesia, so they're not awake. It's painless. They may wake up with a bit of a headache, but it's transient. Um, and we use it in patients with schizophrenia who are not responding well, even to clozapine. Um, and the drawback, the main drawback now is memory impairment. And it doesn't erase people's identity or long-term memories. It does interfere with short-term memory and creating new memories during the kind of interval the ECT is being delivered. But nonetheless, it can be troubling. Um, and we have a study going on at UBC Hospital now looking at a alternative of sorts to ECT called magnetic seizure therapy, MST. And there was a segment recently on The Current, CBC, The Current, just last week you might want to check out. And the host interviewed a psychiatrist at CAMH in Toronto about magnetic seizure therapy. And they've studied it for severe depression. And there was a publication recently on that study, and that kind of occasioned this interview. Um, but they discuss it all in plain language, so I think it would be great if some of you are interested to listen. But we're studying it now in schizophrenia. There's some patients in Toronto and here in Vancouver that will be getting ECT or MST. It's a randomized trial, but we don't know yet how effective it might be in schizophrenia. So, um, but based on the study for depression, I guess the hopes are that it will be approved by Health Canada to treat depression because it's not yet approved. It's only, allowed for research, but we're hoping it will be approved for at least depression, in the next year or so. Um, the final thing, I guess I should come back to is I kind of dropped a hint about a new medication. It's available in the United States, but nowhere else yet. But um, the the company that markets this medicine called Cobenfy, I think, is looking at other markets. So we'll see if it's submitted to Health Canada, but it hasn't been. I won't go into the, kind of neurophysiology of Cobenfy, but it's an interesting treatment. It's actually two medications, two molecules in one pill. One is the therapeutic agent, the other is just counteracting side effects that would ordinarily happen if you took the therapeutic, you know, um, medication by itself. Um, in any event, uh, the advantage is, other than having some mostly gastrointestinal side effects like nausea, vomiting, um, which are usually transient for a couple of weeks. It has very few side effects that other antipsychotics have. It doesn't cause the movement disorders, the minimal sedation, um, no weight gain. So, that all sounds very attractive. And it does have efficacy in schizophrenia, sort of uncomplicated schizophrenia, but I think we're waiting to see how it does in the real world, people with concurrent substance use or medical problems, mood disorders, treatment resistance, all these things that um, complicate our the patient's treatments. So I think I'll stop there. so we can get to more of the questions.
Great. Thank you so much. That was a great overview. And maybe we could start with some of the questions just as we continue to talk about medication and treatment. There were a couple of questions we had sent in about, is there a more natural medication like Respirodon? Respirodon? Oh, I can't hear you. Can everyone else hear him?
Sorry,
Okay.
I muted for a second so I could clear my throat.
Okay, sure.
I'm back. So, yeah, what does natural mean in this circumstance? I mean, if it means like something that exists in nature, the only thing that comes to my mind is uh, a medication that has been used to treat psychosis in the past, but we never use it anymore because for different reasons I can come back to. But anyway, it's called reserpine. Um, and it comes from a plant. I think it was originally discovered in India. Um, and it depletes dopamine in the brain. So I don't remember the exact mechanism, but anyway, you take this for a little while and you lose a lot of dopamine. You also lose another important neurotransmitter called norepinephrine. So it can reduce psychosis effectively. I've never prescribed it for this, honestly, because it was considered obsolete when I was a medical student, but um, the psychosis may go away, but the problem is it can also cause depression and increases the risk for suicide. It was also used to treat high blood pressure because it lowers blood pressure too by depleting norepinephrine. So anyway, if your patient uh, has hypotension and faints or becomes depressed and suicidal, we don't consider that as much of a success. So we're not prescribing reserpine anymore, I'm afraid. And I don't know of any other kind of naturally occurring antipsychotics.
Mhm. Okay, thank you for that. There was also in the chat, yeah, just is there essentially no treatment other than pharmaceuticals for patients with a serious mental illness? And what about other treatments like trauma therapies, psychosocial rehabilitation, cognitive remediation? What are your thoughts on that?
Mhm. Well, of course, all those treatments are important adjuncts to medication. I focus on the medication because, just because I know that a lot of people are curious, but, we treat patients with severe mental illness in team settings, which I've already alluded to. And, we have members of the team who help us deliver, these other aspects of care, everything from motivating patients to, take care of themselves, which our nurses spend a lot of time doing, just getting them to take baths or, wash their clothes, all the way to, you know, the cognitive remediation, which is a specific treatment for the cognitive deficits that occur in schizophrenia, which are not quite ubiquitous, but we know occur in the majority of patients. Um, and, unfortunately, those are not always recognized, or they're certainly not always well kind of, um, I guess, explored or documented in a given patient because a neuropsychologist really needs to do testing, specialized testing to look at all the domains of cognition. There's 7 domains of cognition that are affected in schizophrenia typically. Um, this has, been well researched for decades now. And the BC Psychosis Program, at UBC, we do neuropsychology testing on all the patients, but unfortunately, most teams don't have access to that.
Mhm.
But even without that, there's some basic cognitive tests that can be done, and the Ministry of Health has or is funding some cognitive remediation, um, skill building in all the health authorities. And a psychologist, Dr. Menon, who used to work with me at UBC Hospital, is helping lead that project, working especially with occupational therapists in community settings. Um,
We
so,
have him coming in May to speak to us.
oh, do you? Great.
Yeah,
Okay. Well,
which is great.
I
No,
won't
that's great.
steal
That's
his
it.
thunder.
No, that's great. There was a question, what makes the psychosis program at UBC special? Maybe you wanted to talk a little bit more about that.
Um, well, I guess I already mentioned one thing, which is that we have the luxury of, you know, our own neuropsychologist, also a general psychologist who collaborates on the cognitive testing as well as therapeutic interventions like the CRT, like CBT, etc. We have full-time occupational therapists, recreation therapists. A lot of teams have some of these things, but we're lucky that we have them all in one place. We're able to do very thorough assessments on our patients. Um, and every patient has a diagnostic case conference where all our disciplines come together to kind of review their psychiatric history and all the testing results. We have a half-time family doctor who assesses the patients. We have access to, specialists at UBC Hospital and VGH. We also have a behavioral neurologist, Dr. Bob Stowe, who we can call upon when patients have certain sort of neuropsychiatric features to help assess the patients. So we have a lot of resources. We have a lot of professionals who are dedicated to this population of people with severe schizophrenia, schizoaffective disorder. We also have some clinical trials. I mentioned the MASS study for magnetic seizure therapy. Dr. Stowe has led a study too on genetics in our population. And we've published a number of things on that. We have also a clinical pharmacy specialist who is doing some work on clozapine and how clozapine is metabolized. And possibly we're going to be looking at a new way to test for blood levels of clozapine, which is something important to make sure the patients are on the correct dose. But it takes several days to get results back, so we're hoping we'll have a more rapid way to analyze that. And then, we also, of course, try to involve students and residents so they can learn more about treating people with severe schizophrenia.
Great. Well, no, I've heard great things about your program. So thanks for sharing more about that. There was a question, does UBC Department of Psychiatry have interest in joining other universities such as McMaster's or McLean's in researching the ketogenic diet as an adjunct therapy in the treatment of serious mental illness?
The ketogenic diet is not something I'm highly familiar with for treating schizophrenia. I did, just as you could do, an AI search just to teach myself a little bit about it. And, there have been some pilot studies, it seems. I found one from Stanford University. They had 20 some odd patients. So anyway, a ketogenic diet is, originally developed to put people into this state of ketosis, where they're not using glucose as the primary fuel. They turn to these other molecules that the body generates under semi-starvation called ketones, ketone bodies. So it's, been promoted as a weight loss method, but it does have some effects on the central nervous system. And there are a couple of rare forms of epilepsy that seem to respond to this kind of diet. the diets, they have to be followed strictly. It's not a casual thing. So we're talking about, reducing carbohydrate input to below 30%. And then fat goes up to like 60%. So, uh, in general, it doesn't sound very healthy to me. I follow a kind of Mediterranean plant-based diet. Um, and but you're not supposed to eat starchy vegetables and any other kinds of carbs. So anyway, most people, most patients, certainly with these disorders I know, it would be hard for them to follow, so it would require a lot of support. And the evidence for it is that it can help their metabolic health, and we know that many of them are overweight. They may have lipid abnormalities like high cholesterol or high triglycerides, um, high glucose even, or diabetes, pre-diabetes. Um, so they might lose weight. That could be beneficial. The effects on their mental health, I think, is still kind of being researched and understood. I don't think there's really robust evidence yet that it would be necessarily the most effective treatment for severe schizophrenia.
Thank you. And how do people get referred to the UBC psychosis program?
Um, that has to go through the treatment team. So, the treatment team would refer the person, and there's a process within each health authority, um, like a committee that oversees the referrals to the what we call tertiary mental health. And that brings me to actually something I wanted to share just briefly, um, some illustrations from a presentation I gave a few years back to the BC Schizophrenia Society on tertiary mental health. It relates to another question that was among these, which was about what happened to people who were discharged from Riverview. Um, so let me see if I can. I'll try really, and we'll see how this goes to show you from my side this PowerPoint. Oops. Okay. All right. So is that visible? Okay. Oh, um, okay. So the are you seeing the PowerPoint? Good. Okay, because some weird news thing flashed up on, on my screens. Okay. So let's see. So Riverview closed in 2012, although the process to close it took quite a while. And then there was this whole thing led by the Provincial Health Services Agency, um, to create a network of tertiary mental health programs throughout the province. Um, so yeah, this started in 2002. Um, the health authorities developed replacement beds, 916 bed or bed equivalents. I don't know what a bed equivalent is, but and so, but by the end, this was, I think, in 2017 or 18, I got this inventory from the Ministry of the number of tertiary mental health beds. So tertiary means so the primary treatment would be in the community. Secondary would be in an acute hospital, General Hospital, Vancouver General, Kelowna General, the hospital up in Prince George. And then tertiary is the next level for patients who still need ongoing treatment and care because of severe mental illness. So this is the number of that kind of treatment bed in each health authority. The number six PHSA, that's called Provincial Health Services Authority. And they used to operate Riverview. Now they operate Redfish Healing Center. And they also fund, they don't operate, but they fund the BC Psychosis Program at UBC Hospital. It's operated by Vancouver Coastal Health, but I think that's included in this 364 number. Um, so, according to the ministry, almost 1,300 beds. But, since then, there have been even more beds opened. There are some units out in Maple Ridge called Alouette, which are very long-term beds now that have been established, and they're going to open some similar beds in Northern Health, and supposedly each health authority will have similar beds. So, because it was recognized that there are some people who were not, most tertiary beds were meant to serve people for, let's say, anywhere between 6 months and 24 months. The BC Psychosis Program, our average length of stay is about 6 months. There are some people who, for various reasons, beyond 24 months, still are not able to function, still require a very supportive environment. So these are the locations of the different tertiary beds. And you can see, of course, many of them are in the Lower Mainland, quite a few scattered in the lower part of the interior. So, yeah, some of this is obsolete, so I'm not going to go through all of this now, but I just wanted to, I guess, make the point that I'm going to stop this. Let's see, how do I stop sharing?
Okay, well, thank you for that.
Yeah. Is it going away?
Nope.
How do I make it stop? Why can't
So
I?
there
Yeah,
should be maybe on the top of your, oh, you got it.
You're
I
good.
got it. Yeah.
Yeah.
So anyway, so yes, those beds are probably still inadequate, and we know that there are people who need this kind of long-term care, and so we'll see how that evolves.
Hmm. Okay, thank you. Another question is, how can GPs better help families? Oh, you're on mute again.
GPs do play a very important role in mental health care. In fact, when it comes to, kind of physician involvement and prescribing for mental health, I think the last I checked, it was like more than 80% of that is provided by family physicians, and now there are a growing number of nurse practitioners who are providing primary care. But most of that is for things like anxiety and depression and, uncomplicated substance use disorders and etc. When it comes to more severe mental illnesses, I think most family physicians, will readily admit that they get out of their depth, and they really want a psychiatrist to be involved. And of course, sometimes that's hard to come by. And I think for people with severe and persistent mental illness, you know, delivering the mental health care is not really an expectation so much. What is would be assisting in managing the comorbid or the kind of concomitant medical conditions that so many patients have, because, we know that people with severe schizophrenia live, 15, 20 years less, like their lifespan is reduced by that much compared to the general population. That's largely due to the same things that will cause many of us, our final breaths, heart attacks, strokes, etc. But in people with schizophrenia, they happen much sooner. And I've already talked about, being overweight, diabetes. Of course, there's tobacco use. Still, the majority of people with schizophrenia use tobacco. So, um, I have a window open and an airplane flew over. Um, so, I think family physicians play a really key role in helping manage those disorders and risk factors. Um, Psychiatrists are becoming a little bit more comfortable with some of this, and I think we have to. And there's a special clinic in, for instance, Center for Addiction and Mental Health in Toronto. It's run by psychiatrists for metabolic disorders and people with severe mental illness, and they're prescribing things like metformin and um, semaglutide or Ozempic. But most psychiatrists are not comfortable doing this, so we really have to rely on family medicine.
Thank you. There's a question here. How do we support and not blame someone who has caused us harm because of symptoms of their illness?
Um, yes, when I read the questions, that one certainly stood out. And Gosh, I don't think I have an easy answer here. Um, and I think when things like that happen, they can't be ignored, though. And I talked a little while ago about the risks and the burnout that families face, and this would certainly be, something that could lead to that. And I think families do have to set certain boundaries. I can't give a prescription for how to do that or when to do it, but um, ideally, the care team involved with the person with the illness would assist especially when there are high risk things like aggression, um, extreme paranoia, etc. Most people with psychosis or schizophrenia do not become violent or do not harm other people, but there is overall in the population a higher risk of this than in, the general population. And it usually does relate to, extreme paranoia, delusions about their own safety, which lead them to, act inappropriately toward other people because they feel their own safety is somehow being threatened. And, it's quite terrible when the kind of object of that is a family member or somebody, living close to them. Um, and, we talked, some of you, I think, attended the Frames of Mind where we looked at a film that is very relevant to all this of a man with severe schizophrenia living with his parents. And, you know, one idea about that situation was that this man could have had a kind of misidentification delusion where he thought the family members maybe were imposters or something. In any event, that's a kind of a high risk delusion that we psychiatrists need to diagnose and pay attention to. But so if something aggressive happens, then obviously, the family will need to process that. Why did it happen? Was there a delusion? What led up to this? And the care team would play a crucial role in kind of trying to understand that. So that would be the first step, I think, in acceptance to, hopefully understand how it happened. It was a product of the disorder. Um, and then, how can it be prevented from happening again. And there was probably a role for some individual counseling for any person who was traumatized in that way. And there are um, you know, counselors who work with families affected by severe mental illness here and there, but of course, it may not be covered by um, the provincial health insurance.
Okay, thank you. Um, Another question. Do you have some strategies to navigate or help our loved ones to accept the diagnosis?
Well, except the diagnosis is uh, may or may not be um, a goal depending on what's going on. Now, I spoke last year about this concept of insight, um, and that's a person's awareness of. I mean, it can be used in many situations. It doesn't have to just apply to schizophrenia. You know, all of us have insight, hopefully, to some extent, into how what we say and do affects other people and, our internal motivations, etc. Uh, it exists on a spectrum, and in mental illness, um, you know, there is a loss of that self-awareness, that insight, um, and it can go all the way to the extreme end of the spectrum where there's absolutely no ability, and it's likely kind of a neuropsychiatric disorder called anosognosia, and the person affected really cannot see that they have an illness or that their delusions, their hallucinations are a product of that illness. To them, they're real, and all of us who don't accept that are the ones who are mistaken. So, excuse me, getting someone to accept their diagnosis under the circumstances would be, to some extent, futile. So, um, but for people on the more mild end of the spectrum, it could certainly be a goal. But again, lecturing someone about it is unlikely to be helpful. So, um, some of you may be familiar with the psychologist who wrote a books. I think the book's been out for more than 20 years, Xavier Amador. Um, the book is I'm Not Sick and I Don't Need Help. And he outlines an approach which is basically motivational interviewing, which is a common kind of counseling or therapy to help people move in a direction that will be healthy for them, but for whatever reason, they're having a lot of difficulty with. It started really as an approach to dealing with smoking to help people quit using tobacco. And then it was generalized to other addictions, other substance uses, and then to other kinds of change, weight loss, behavior problems. And so, Dr. Amador kind of modified it for people who are dealing with someone with psychosis. And he has this little acronym LEAP. So listen, empathize, agree, and partner. And agree doesn't mean actually agreeing, yes, your delusions are real. It means finding reality-based things that you and the person can agree on that help with, establishing kind of your relationship, your rapport, and that you can build on to help the person achieve, useful goals, whatever those might be. Taking a walk around the block once a day, or getting a job, or going back to school, whatever. And that treatment would be the pathway to achieving goals. So anyway, that's kind of the approach really
Mhm.
motivational
Yeah,
interviewing.
yeah, those are great strategies. And actually, for anyone in the Vancouver area, we will have a series, we're calling it communication upskilling, and we'll be going over the LEAP method as well as nonviolent communication in this series in June. So people can check our website. But definitely learning different communication tactics and techniques can be helpful strategy. Mhm. Okay. Um, any advice on how to deal with the lack of care and resources for long-term mental health patients?
Um, well, I mean, I was talking about that a moment ago, when it comes to like the tertiary mental health system. So, um, every person has some unique needs. I I think we're compared to some jurisdictions here in the Lower Mainland, we're we're fairly well off when it comes to supportive housing. There's not enough of it, but we do have some very good nonprofits that operate supportive housing, like Coast Mental Health. Um, and they get money from the health authorities directly. They have to raise a lot of money too, to build this kind of housing. Um, and so we just need more of that, and figuring out ways to support those agencies and to um, get more funding for them, I think is key. Um, and then for some people who do require a tertiary level of care indefinitely, um, there is greater realization of this, and some of this is because of this population that seems to be growing of people with kind of a combination of severe mental disorder that may have been pre-existing, uh, with addiction, leading to overdose with fentanyl or, metamidine or whatever the horrible stuff is this week on the street. And then, brain damage. And unfortunately, that really limits the rehabilitation possibilities. And there really is a need for kind of basics custodial care. Um, and that's part of what the Alouette units are are meant for. Um, so more of those are supposedly coming in other regions.
Mm-hmm. Let's hope for that. Okay. One question from a family member. How can we convince psychiatrists of the necessity to share information with parents?
Well, I think I went through that in my, kind of opening remarks.
Mhm.
I mean, I think that the fact that especially if the person, like I said, is living with you, you're in the circle of care, and I don't think that excluding the family in that circumstance by any means makes sense. So, um, I think you have every right to try to make that known to the care team. Um, you have to be a partner because you're going to be, they're in the hospital for 2 weeks and then they're with you 50 weeks in each year. So, um, but, you know, physicians have been taught from day one in medical school about confidentiality, and, the Hippocratic Oath has a sentence right in it about that. And so, you know, the fact though that if someone has a severe mental illness and let's say they even have anosognosia, so they're not accepting their diagnosis, they're they can't really have a meaningful discussion about their treatment. And even though the Mental Health Act uh, doesn't require any kind of substitute decision maker, um, the person who's going to be, providing support and care in the community, though, still has to understand what the treatment plan is, or else it's going to fail.
Yeah, yeah. Thank you for that. Um, Staff need better training about the value of family involvement for clients with schizophrenia. How can this happen? Well, I think this is all on the same theme, but um, do you see any more better training happening around family involvement in the mental health system?
Um, I mean, yes and no. I mean, I think that we have good initiatives here and there. There's the family involvement program at Vancouver General. We have one in the community. Um, and I know a number of you have attended those. Um, doesn't always translate into what happens in the psychiatry units. Um, but I would like to, and I should know, but honestly, I don't know exactly what the residents are learning. I mean, when I lecture the residents, I do bring this up, but I'm not sure there are lots of us who lecture psychiatry residents, so I don't know what they're hearing in every lecture they're getting. Um, I don't think they have a specific lecture on this in general psychiatry. Um, so maybe soon I'll try to find out more about that. I know, and when it comes to psychiatric nurses, there's a particular designation in BC. BC and Alberta, I think there might be another province has RPNs, registered psychiatric nurses, and so they have a unique curriculum. Um, and I don't know what they learned about that. I
Mm,
should ask them.
that would be great. Yeah. Um, there was another question related to that, just about certainly families having, the medical history and how does the family caregiver find out which information the doctor knows about or has access to from so many different in and outpatient settings? And how then do we decide which information to offer as collateral in hopes of, for example, an extended leave being renewed or continued certification being strongly defended?
Um, well, let's see. I could start maybe kind of on a technical level. Um, eh, Maybe this is irrelevant to you all, but I'll just mention that um, we have a kind of messy landscape of electronic health records in BC. Um, that's what doctors rely on to get, basic information, someone showing up in the emergency department or in the hospital unit, and we want to know their history. We're going to start with what we can find in the medical records. So it's certainly a lot more efficient than it used to be, 10, 20 years ago when there were paper charts and we would have to have things faxed from, we would just kind of scattershot to all the hospitals, faxes, whatever you have you know, on this person. Um, so we don't have to do that anymore, but we do have to log into this system called Care Connect. And there's a lot we can get there. We can get discharge summaries and consultation reports from most hospitals right now throughout the province, at least going back, 5 or 10 years. Um, but um, but that's hospitals. When it comes to community treatment programs, That's really kind of yeah, it's I don't want to use the word disaster, but anyway, it's not very good. So in Vancouver, we've got um, three electronic health records, Cerner in the hospital, and a few community programs, Paris at some mental health teams, and then Profile EMR at other teams. These don't really talk to each other. Um, and so if you want to, someone's coming into hospital and their team uses Paris, you can get some stuff, but key things like what medications they're getting, you may not have. So, in general, doctors can get a lot, they can't get everything. So, um, I think if you have a list of medications, the most current medications, um, allergies, and the name of the family doctor and how to reach them, just that very basic stuff to offer as soon as possible. That's always, I think, very helpful and appreciated. Um, and if somebody has come to BC from another province, then all bets are off. And if you were to have documents from elsewhere, I think that would always be great. Or at least be able to tell us that the person was treated in this city and went to this hospital, and then we can try to obtain it. Um, so it's just another thing to consider, I guess. And when it comes to review panels, um, you know, I think that's when, the family input is, if the person is, again, is living at home in particular, is key. And you know, I've used input from families a number of times in review panels, and it puts you all in a bind, I know, because on the one hand, um, you want us to be able to, explain what's going on when the person's at home or when they're in the community and why it's not going well, or the, difficult behaviors or the non-adherence that you've observed. Non-adherence might, like, refusing meds or whatever. But at the same time, uh, I've had, I think in most cases, family members saying, please don't say I said this, or, you know, a few of them have said, well, I'll come to the review panel, but only if, they don't know I'm there. But we can't do it that way. It doesn't work. So, like, we can't have a witness show up and the person who's certified not know who the witness is, right? It's not legally allowed. So anyway, so there is a bind, I know, but if you can at least get the information directly to the doctor who's going to sit in the review panel, I think that's really important.
Okay, thank you. Um, Another question, are there any advancements in psychiatry and treatment plans with AI available now?
Sorry, to finish up my last
Oh,
thought,
sorry.
if you can write a letter and submit it to the doctor,
Okay, yeah.
even if they won't take your phone call, just hand it to the nurse. Here's my letter. I want the
Mhm.
doctor to have this before the review panel.
Right.
Yeah.
Thank you.
Okay, sorry. What was the question?
That's okay. So it is, are any, are there any advancements in psychiatry and treatment plans with AI available
Oh,
now?
um, I mean, I think it's an active area of kind of research and development. I'm not aware that we're doing that yet here in BC, other than um, what are called AI scribes. And this really isn't for patients and treatment planning as much as just to make things more efficient for hospital staff and doctors. So, we can use one of these programs, applications during the, session with the patient with the patient's permission, of course, uh, and it will listen, take the information in, the exchange of information, and then turn it into a clinical document. Um, but that same kind of technology, I think, is being used to then anonymized, of course, to um, you know, uh, through whatever machine learning, figure out how to more accurately diagnose patients. Um, through the syntax of their speech, through their vocal tone, and all that information, can be analyzed on a population level, and then come up with models that allow, more accurate diagnoses. So, um, and then also, the information gathered from, both the patient's kind of mental status, diagnosis, as well as like lab tests and um, other medical information can be used, and how they respond to medications to determine, which medications may be more suitable or effective for certain kinds of patients. And I know that'll be coming. But um, we're not able to use that yet, but I think it's just a matter of time.
Thank you. And there is a question about involuntary care models and best practices. Um, who's doing it best?
Who's doing it best? What? Sorry, can you explain a little more?
The involuntary care models.
Okay.
Yeah. So we know that, we do have involuntary care
Mhm.
here. Do you know about, who else is doing involuntary care and
Well,
who?
I mean, every province in Canada has a mental health act.
Mhm.
Um, some of them allow patients to be hospitalized or detained in a hospital involuntarily for diagnosis, but not necessarily for treatment. Um, and an extra step, legal step, has to be taken to authorize involuntary treatment. So it often would require, the decision of a judge um, to allow that treatment. Um, and then patients can appeal those decisions. So in some cases, it can take months to allow a patient to receive treatment. Um, and some of these patients are actually not capable of making those decisions, at least from a psychiatrist point of view. But under the law, they're still considered competent adults until proven otherwise. So that's kind of the decision judges make. Are they competent or not? And so in BC, we are allowed to treat patients once they're detained under the Mental Health Act. And, you know, if we consider that they're not,
Hello?
oops,
Hello?
um, so if they're considered not to be capable by our assessments, um, we can require them to take medication. So it doesn't mean that we coerce medication in every case, but um, certainly if it's a life or death situation, um, we will do that if necessary. Um, Now, that's just for psychiatric treatment, mental health care. It's not for general medical care. So we can end up with difficult situations where we can treat someone for their schizophrenia, but they have, whatever cancer we discover. I mean, that's happened more than once. At BC Psychosis program, we assess people. They haven't seen a doctor sometimes in quite a while, and had a thorough medical workup, and then we diagnose a serious disorder like cancer, and we try to obtain the patients the consent for treatment. Sometimes they give it, sometimes they don't. But anyway, that's a separate matter. But when it comes to mental health care here in BC, um, and most provinces don't allow that, but we are here able to treat them.
Mhm. Okay, thank you. There was a question here. If UBC has any programs going on that are utilizing the work of Dr. Ammon, is there a SPECT scanning done at UBC?
Oh, Dr. Amen, right?
Mm-hmm.
Yeah. Um, yeah, he's a psychiatrist, I think, in Seattle and has a clinic where he does these scans. Um, and you know, although those SPECT scans can give some information, they're actually not specific enough to allow a particular diagnosis. That's one of our, I guess, our weaknesses in psychiatry. We don't have tests that can tell us, patient A has schizophrenia, patient B has schizoaffective disorder. It's all done by our clinical assessments, including things like family history and the neuropsychology testing and all that is helpful, but it's the global picture. It's not one test. So, um, you know, um, with all respect to Dr. Eiman, I'm sure he's doing some good work, but I don't think spec tests are the end all and be all.
Okay, thank you. And that's why it takes the team, right? It takes a team, it takes a family, takes people around you that care. Yeah.
Yeah.
Um, so we are at 8:30. We should wrap it up. We appreciate your time. I'm sorry that we didn't get to all of the questions. Aurelia will be sending out a survey after we wrap up, and we'll also send out that the current article or episode that you mentioned in that as well. So yeah, we just really appreciate your time and your expertise today, Dr. White. Thank you so much for taking time. And thank you all for being here. Um, thank you so much. Yeah, you can do your reactions. I love the reactions.
Well, thank you for all the work you're doing to advocate for our most vulnerable patients.
Absolutely. Okay, well, thank you so much, everyone. And I hope you have a wonderful evening. Yeah,
All right.
thank you. Thanks so much.